a tener una conferencia de la doctora Alba Menchú y después vamos a realizar un panel de discusión donde va a estar Sueli Resel de Brasil y por lo que es, va a ser muy productivo el día de hoy. El profesor Farrugia ya fue presentado el día de ayer, pero creo que merece ser nuevamente presentado. El profesor ha sido un referente en todo lo que son hemoderivados a nivel mundial, con una trayectoria de más de 35 años y ha ocupado altos cargos a niveles de bancos de sangre, tanto en centros de fraccionamiento y ha participado en agencias gubernamentales en la regulación de los mismos. Ha sido miembro de organismos internacionales como la OMS, el Consejo Europeo, la Federación Mundial de Haemophilia y comisiones de farmacopea de Estados Unidos y Europa. Actualmente se desempeña como profesor adjunto en la Escuela de Cirugía de la Universidad de Australia Occidental y tiene muchísimas publicaciones con respecto a todo el manejo de personas con trastornos hemorrágicos y con el manejo de diferentes productos derivados del plasma. Esto es un resumen de toda su larga trayectoria en lo que es el manejo y el tratamiento de este tipo de pacientes. Comenzamos con la conferencia del doctor Farrugia.
Okay, is this on? Hello? Okay. Okay, yes, thank you again, and good morning. Let me see. How do I advance this? How do I do this? Yeah, but to move them forward. Okay. All right. Very good. Okay, thank you very much. Sorry about that slight delay. Okay, so this morning I was asked to address issues which are related to the question of pharmacoeconomics and related to treatment, and perhaps some issues also related to ethics, which are very important for us. This is an area which I have been involved in for some years, mostly from the point of view of assessing the economic aspects involved in improving treatment, such as the question of prophylaxis versus on-demand therapy in the mainstream non-inhibitor-based hemophilia without inhibitor. And I approached this level of work from a position 5 or so years ago of total ignorance. I knew nothing about this field at all. I knew it existed, but I didn't really know much about it. But I was struck, I was interested in the way in which the people who are experts used a certain language in relation to how they came about to do these types of assessments. And this is a sort of a statement, this is in fact the title of a chapter by Dr. Alec Miners, who was one of the very first people to start looking at the pharmacoeconomics of hemophilia. And it says, you know, does prophylaxis with clotting factor represent value for money? And this is something which, a phrase which, you know, occurs time and time again, value for money, value for money. Now, I am interested in assessing more this concept of value for money. The kindest country in the world, the most generous country in the world in relation to hemophilia, it is a rich country, but not as rich as other countries, is Sweden. And this is a slide which I call in praise of Sweden. That is the Swedish flag. And what we're talking about here in this talk really is the concept of reimbursement. In other words, how do we pay for the treatment of hemophilia, specifically in the talk I'm going to give you, the treatment of hemophilia with inhibitor. And Sweden, which is a socialized economy, Sweden is a free market economy, but it's based upon what we call the social market, which means that the government itself has a very big role and pays directly for drugs. Does this, as do most countries, through a specific organization within the government, which is called the Swedish Pharmaceutical Benefits Board. This is the English translation. And the documents of principle, if you like, the documents which describe the principles whereby Sweden decides whether to reimburse medicines included a statement, which I quite like. And you can see from the statement, and the slides are available to you if you want them, this is all public information, that they use 3 criteria when deciding if a medicine should be paid for. And one of them is the human value principle, which underlies the respect for equality of all human beings and the integrity of every individual. The next one is the need and solidarity principle, which says that those in the greatest need take precedence, are given priority when it comes to reimbursing pharmaceuticals. In other words, people with more severe diseases are prioritized over people with less severe conditions. And then there is the cost effectiveness principle, which states that the cost for using a medicine should be reasonable, but I emphasize from a medical, humanitarian, and social economic perspective. I think it's very important to keep these principles in mind. I spent time in discussing this because many times, and I will show you a lot of what I might call abstract concepts now, concepts related to economics and statistics and so on, but many times we need to remember that behind all this and based in all this is the concept of humanity, solidarity, and the treatment of people who are in need. And I will come back to Sweden later on in this talk. So just to very briefly go over again the questions of inhibitors, I think much of what is here I have already spoken about yesterday during the industry symposium. But you know that now we recognize that this is a severe problem, especially for hemophilia A. 25 to 30% of patients get inhibitors. In hemophilia B, it is nowhere as high. However, if a person with hemophilia B gets an inhibitor, it's, as you know, a therapeutic nightmare, because the inhibitor treatment in hemophilia B is much, much more complicated and much less successful than hemophilia A. We discussed yesterday that generally inhibitors develop during the first 50 days of exposure, and that they result in a reduction of efficacy and an increased morbidity. I'll show you some more slides again. They result in progressive and severe joint disease and disability, and irrespective of how you do it, if you treat inhibitor, it's going to be, using the current costing systems, very expensive. Here is a summary of the data to demonstrate the dramatic problem of inhibitors. You can see here in this survey from the United States, you can see how many more patients with inhibitors, 23% versus 2%, developed severe arthropathy compared to the people with hemophilia without inhibitors. And this is from Massimo Morfini in our country, in Italy, assessing quality of life. And basically you can see that compared to severe hemophilia without inhibitors, hemophilia with inhibitor led to much decreased quality of life. So this is a bad thing, to put it simply, which needs to be addressed. To summarize again, I think I showed you this slide yesterday, the approach is to treat the bleeds using bypassing agents, to prevent the bleeds through prophylaxis if possible, but most importantly, to eradicate the inhibitor through immune tolerance induction. And I am now going to go over some pharmacoeconomic studies, some studies involving the cost effectiveness of the various treatments compared to each other. So let's start with the treatment using the bypassing agents. This is a slide constructed by Cedric Hermans in Brussels, summarizing the key studies using activated prothrombin complex concentrates and recombinant 7A. It is a good bit of work, this slide. It summarizes many studies. The important point to note is that the success rates treating acute bleeding episodes when compared to the use of factor 8 and 9 in non-inhibitor hemophilia A or B is lower. Basically, you can see 81%, 81% again, 88%, 92% in the work here on factor 7A. It's a bit difficult to know which is making the most noise, in here or out there. It would be good if somebody were to tell the people out there. It would be polite for them to stop. Anyway, to come back, I hope this won't happen again. It reminded me of a James Bond movie, that sound. You may remember it yourself. So basically, we know that factor 8 and factor 9 in normal hemophilia patients, if there's such a thing, are actually very successful. We expect success rates exceeding 95% in efficacy. It's not the case when we treat patients with inhibitor with the bypassing agents. It's important to recognize this. Okay, I showed you this slide yesterday to show you that overall, in a direct head-to-head trial between the APPCC, the FIBA, and the factor 7A, the Novo Nordisk product, overall, over the two populations of inhibitor patients, there seems to be little difference in efficacy. Although I did emphasize that when looking at individual patients, there were differences either way. This is a study now using the PHENOX study data, using, in other words, the data from this comparison, which was called the PHENOX study. This is a study by hemophilia treaters in Sweden, Sten Carlsen and others, which did a cost-effectiveness analysis between FABA and recombinant 7A based on the clinical data in the PHENOX study. In other words, they took these numbers in relation to efficacy, they really analyzed them very thoroughly, and then they assessed it relative to 3 countries, the United States, Sweden, and Turkey, using the costs for treatment with the different drugs in these 3 different countries. You have to do this because companies price their products in different ways. In the United States, the companies charge much higher prices than in most other countries because there is relatively little control, although now the insurers are getting worried and are trying to get some level of control on price, and therefore they charge pretty much what they like. And we, patients in the other parts of the world, are very grateful to the authorities of the United States who allow this, because then we are able to exploit this finding in our own economies and drive the prices down considerably. And the companies sometimes are not so worried because they know they can continue to exploit the United States population. I put this somewhat simplistically and certainly in some level of humor, but it's definitely the case that for all medicines in the world, whether you're taking statins or you're taking recombinant factor 8, the Americans seem to be willing to be ripped off infinitely more than any other country in the world, and we are, of course, appreciative of the sacrifice that they do for us all. The important point is that in this cost-effectiveness study, treatment with FABA resulted in cost savings. In other words, FABA was more cost-effective relative to factor 7A. I am simply reporting data here. I'm not advocating any kind of therapeutic decision. I am reporting data in the public domain through the literature in relation to this finding. So this is one study. However, it's important to note this is not the only study. Now, you will see many of this kind of diagram. This is a cost-effectiveness analysis. We call this a decision tree. Basically, what we have here is pretty much the therapeutic options demonstrated in this decision tree in relation to the different types of decisions which can be made, whether you're using FABA or FABA down here or factor 7A, whether the bleeding stops or continues, what you do then, and so on and so forth. In other words, this attempts to demonstrate in this decision analysis all the clinical decision points which are possible with dealing with patients using either of the 2 therapeutic choices. inputting through the relevant parts of the mathematical model the actual costs and the results and seeing what happens. And this decision tree was constructed for the case of mild to moderate bleeding with inhibitors in Korea. So this is in Korea. And the interesting thing is that compared to the study showing the same type of analysis between the United States, Sweden and Turkey, in Korea they found that actually it was the opposite type of result and recombinant 7A was more cost effective. Now, I don't want to take too much time to explain exactly how this diagram is constructed, but basically over here you can see the decision outcomes for the 7A. The white part is the decision outcomes for the FABA-type product, and basically the bigger one shows the more cost-effective one. When I say more cost-effective, you have to understand that the people who developed the science have certain criteria by which they define cost-effectiveness. In other words, they say a drug is more cost-effective than another drug based on these criteria. Now, I'm not going to get into exactly what the criteria are, but they involve the assessment of the quality of life and the effectiveness and all the issues which are involved in a therapeutic progression. So that is what I mean. In this study, therefore, in Korea, they consider that the Novo 7 is more cost effective. To make it more interesting, here is an exactly similar study of recombinant 7A versus the FABA-type product, again in the treatment of mild to moderate for severe haemophilia and inhibitors in Spain. And this is a very similar type of analysis to the analysis which I showed you for Korea. And in this analysis, we actually get roughly the same result. In other words, there is not much difference in the cost effectiveness between these two products. Now you might tell me, so why is this happening? Why is it one way in Korea, one way in America, one way in Spain? Well, the reason is very simple. It comes to the price of the drug. The cost effectiveness obviously is related to the cost. And if the relevant authority in a country is able, for some reason or another, to establish a cost which is different for one drug relative to the other, then obviously this will affect the cost effectiveness. And underlying all this is the whole infrastructure of how countries fund the public health and who makes the decisions. And I will come to this point later on in the talk in a more general way. But I would make the point that it's very important to have laws and authorities which are based on the laws, and to have publicly spirited people who are actually doing these negotiations with the pharmaceutical companies and getting the best possible arrangement for the health system and for the relevant community. This is crucial in relation to making these kinds of decisions. It must not be allowed that people are just allowed to take public money or insurance money and make decisions on personal relationships with one company or another. And this is happening all over the world, and it makes me very angry to see in many countries the way in which you see, for example, a specific product always being present. When these days in haemophilia, and I will talk about this later on today, we are very fortunate in practically every aspect of haemophilia that we have a very wide range of products. And this is a good thing. We have done many studies to see whether one product is better than another, but there's definitely a very wide range of products available, and therefore, in order to get the best possible outcomes in these kinds of analysis, and this is why there are these differences, we have to keep this in mind. I hope that is clear, and we can perhaps discuss this later. Let's continue on cost effectiveness. This is a very interesting range of studies here in relation to the cost effectiveness. This is standard prophylaxis regimens with bypassing agents in these three different studies. This is a pro-fiber, it's called the pro-fiber, it doesn't mean it's pro-fiber, it simply means they used the fiber in the prophylaxis, and this is the outcome. This is another fiber-based study, and this is the outcome, and this is the CONCO study, which I will also show in some detail, which looked at recombinant 7A. So you can see here the outcomes with prophylaxis, We are now moving towards prophylaxis as opposed to treatment, as we had before. And you can see here the outcomes in terms of the reduction of the total number of bleeds. In the ProFIBA, we had 62% reduction. In the FIBA-proof study, 73% reduction. The Conkel study, which looked at two different dosages of the recombinant 7A, at 90 micrograms per kilogram, a 45% reduction, and at 270 micrograms per kilogram, a 60% reduction. So obviously, dosage is important. Now, when we look at the costs in relation to these three different types of approaches, observe what we see. If we look at FIBA prophylaxis, this is cost saving relative to daily prophylaxis with recombinant 7A. For every patient treated with 90 micrograms per day of 7A in this study, the Conkel study, 2.31 patients could be treated with the FIBA prophylaxis, as the 90 microgram dose, and for every patient treated with recombinant 7A at the higher dose of 270 micrograms per kilogram per day, you could treat 7 patients with FIBA prophylaxis. This is a slide again, generously provided by my friend Cedric Harms. So I think this study is the kind of analysis which needs to be done when people are making decisions. I'm not saying this should be the only analysis, but this has to be kept very strictly in mind. I have visited hospitals yesterday during dinner, I think with Swelly, we were discussing certain hospitals seem to use certain drugs like water. No questions asked. Very expensive drugs, and no questions asked. Why are you using this drug? Why aren't you using the other drug? Have you read this paper? I urge everybody involved in haemophilia care, whether it is people at the direct interface with treating patients, or whether it's people making decisions in government on what products to buy, to ask these questions and not allow people, all of a sudden you walk into a hospital and you see just one product. Okay, va bene. How much did you actually pay for this product? Did you have a competitive process? Did you try to drive down the price? I will show you later on how to drive down the price. Okay. Now, it's very important, and this afternoon I will say a lot about this in relation to the new products, but it's very important to realize that standard prophylaxis regimens, even in inhibitor patients, are not able to provide bleeding prevention in all patients. I showed you the result of the Phoenix study comparing directly the 7A to the FIBA, and you can see that overall there is no difference. But then when you start looking into individual patients, and in these two sets of data from this study in the United States, you can see between on-demand and prophylaxis in both, in inhibitor patients. And it's quite interesting to see that you get certain patients which have a decrease in bleeding episodes through prophylaxis by 50%. And there are certain patients which have decreases in bleeding episodes by much less than 50%. And the difference between on-demand and prophylaxis is much less. And obviously it is extremely important to study patients on an individual basis and to say, okay, this patient seems to react better to prophylaxis, this is a good thing. This patient doesn't seem to really benefit much from prophylaxis, and we need to make a decision as to whether going to prophylaxis with all its expense is actually justified, or maybe we need to increase the dose or the frequency. These are the kind of decisions which then this kind of analysis can lead to better treatment of the patients. But the important point to notice is we need to have individuals therapy and not just focus on the final numbers. Okay, so having discussed the aspect of prophylaxis and inhibitors, let's go again to the issue which I emphasized greatly yesterday, which is the removal of the problem whenever we can through immune tolerance induction. And I spoke yesterday about this in relation to how important it is, especially for children, to preserve joints and improve quality of life, and that it is a huge economic investment. It's very expensive. You will see this in a few minutes. But if we can provide long-term removal of the inhibitor through tolerance, it will have benefits for the whole of life for the vast majority of the patients. So let's look again at a few of these decision trees. This is one of the earliest ones now, about 16 years ago, from Alan Colwick in London. And basically what you're seeing here is another of these decision trees in which the clinical path is taken for the patient, whether he gets immune tolerance or not, the level of Bethesda unit level inhibitor which there is initially, and this is replicated for both arms, okay? You're just seeing one arm here because there's not enough room on the slide, but all that you're seeing here is replicated for this arm where there is no immune tolerance therapy. Okay, so you can see that then you look at this model, which is quite an early one, the levels of moderate and minor short-term morbidity and major short-term morbidity compared to all the other arms. To death. This is a so-called Markov model. And basically, without getting into the details of this, it's important to know that, again, we have the comparison between the ITI and the non-ITI arms shown in these portions of this cartoon here. And basically what we see here is that ITI is more cost-effective. Again, more cost-effective, more instances where ITI is cost-effective relative to not using the ITI. Okay, another paper which is much later now, from a couple of years ago, doing exactly the same thing, and in this instance we are comparing the ITI treatment to continuing to treat either through prophylaxis or on demand with the bypassing agents. So a very standard level of clinical decision making. Are we going to continue treating with the bypassing agents throughout the life of the patients, whether on prophylaxis or on demand, or are we going to do ITI and remove the inhibitor? Well, observe here what we have, and remember that we're looking here at the whole of life. We're looking at the life cycle, and you can see here that if we do ITI, we're going to get certain level of costs, it's true, and much of these costs are very much initial in the ITI, and then the costs stop. We have a certain level of quality-adjusted life years obtained, and we have a certain number of bleeding events. And compared to the two, treatment as opposed to tolerization modality of on-demand versus prophylaxis with the bypassing agents, you can see that we get much better outcomes overall, over the whole of life. Because it's true that if you do ITI, I mean, this is obvious, right? If you do ITI, you're in for a 1 year to 2 years, if it's successful, to a treatment period of massive costs in terms of factor VIII. But if you keep on treating with FADBA or with 007, that's for life. If the haemophilia patient is going to continue to be treated, you're going to keep on paying that money time and time and time again. This is putting it more simply, but basically this is all that these models are telling us. So ITI is not cost-effective. So, to summarize, this is our points which I made yesterday in relation to other decisions, perhaps the use of plasma-derived, as I said, in young patients because of the CPIT study, and the identification of high risk from genetic and other factors. In terms of proper use of the bypassing agents, we need to choose the right agent, the right dosage, the frequency, and the modality. This is the important point. Personalized treatment. Each patient has to be studied on their own. We have a problem in many countries. It's actually now becoming a bigger problem in the rich countries, where the argument is, well, we're paying these millions of dollars for these expensive recombinant factors. You tell us you want these expensive factors to treat yourself at home. You want longer acting to be able to treat yourself at home. Very good. Here's the factor. Don't come to hospital. We don't want to see you here. We don't want to have expensive haemophilia centers with expensive specialized doctors, specialized nurses, and so on. This is a big problem in my country. We have, in Australia, continuous pressure on the haemophilia treatment centers because we spend huge amounts of factor VIII. We don't spend as much as the Americans because we are a bit more clever. We spend a lot of money. And therefore, to keep the haemophilia treatment center is expensive. But to have personalized treatment, to be able to study and characterize and give you, if you like, a treatment passport to each patient and say, this guy does well on prophylaxis, this guy does not so well with this dose, we have to increase this dose. This guy has good prognostic features in relation to ITI. You have to have the haemophilia treatment center and doctors and nurses making decisions and not just hospital economists. Okay, now again on ITI we should look on this as a long-term investment. I think I have said all this before, it's just a summary, so I will continue. Let us continue therefore looking now at the cost effectiveness of the immune tolerance. Again, another study, I think this one is very recent from haemophilia. I think I actually referred to this paper last year. And again, it's looking at a model in which we are looking at the question of ITI versus prophylaxis and on-demand. This is very recent. These are the inputs in terms of the costs, etc. This is just a grammatic representation. There's a scatter diagram between these four quadrants, okay, showing the differences between the modality of ITI versus prophylaxis and the modality versus on-demand. And basically the summary, the paper is in haemophilia, you can find it, but the summary is that treating patients via ITI inhibitors may result in lower lifetime costs and greater life years, and quality-adjusted life years than treating with bypassing agents. Again, saying the same thing. Here is another study from Spain. This is an interesting study. This actually is another prophylaxis study. It's not with ITI, and I make the point about this one because this is interesting, because it looks at prophylaxis with prothrombin complex activated versus on-demand with 7A. Sorry, there's a mistake there. It should be 7A, not 8A. Okay, excuse me. Now, this is an important point. Why is this study constructed like this? The study is constructed like this because actually recombinant 7A is not licensed for prophylaxis in most countries. There are not enough studies. And in fact, because the half-life, this is quite an important concept, and we'll come to it in the afternoon, because the half-life of 7A is quite short relative to the activity presented by the activated prothrombin complex concentrates. On a hypothetical basis, on a pharmacokinetic basis, it is difficult to see a prophylaxis regimen for 7A. Half-life is only about 2 hours, okay? Well, this is true. What is also true, however, is that there are studies which indicate that you can still achieve a certain level of success. You can still achieve success with prophylaxis on 7A, but it's not licensed. And therefore, these people, this group, which is associated with the Spanish authority for reimbursement, considered only treatments which are licensed in relation to reimbursement. And what they found was that when they looked, just concentrate, if I can ask you on the summary, which is over here, that when there is prophylaxis with the activated prothrombin complex, it's better, results in cost savings 16% less costly than on-demand treatment with recombinant 7A for the Spanish National Health Service. Important, again, for the Spanish specific example. Comparing prophylaxis with APPC versus on-demand with 7A, because those are the licensed indications. This is the ISTH study, much more recent, very, very large study, again, looking at inhibitor patients in all aspects, not just in terms of cost effectiveness vis-a-vis immune tolerance induction, and these are the costs. And I draw your attention to the fact that the cost per patient month in euros for immune tolerance induction is 60,000 euros per patient per month for treatment courses which approximate 14 months. Just think about it. A lot of money. Excuse me while I drink some water. Very expensive treatment, 60,000 euros per month, no joke. However, as is summarized in the final conclusions of the paper, the total costs of ITI therefore approach approximately 1.5 million euros. However, the cost of ITI with a typical duration ranging from 1 to 4 years and the success rate as observed in the study can be buffered, can be countered, can be balanced by the cost of inhibitor patient care in 3 to 13 years. In other words, the money which you spend on ITI, you get back in 3 to 13 years, when you consider that for that period of time you would have been treating the patient with the bypassing agents, because these are not cheap. Everything depends on the costs. Now people might say, well, and this is a very common problem in healthcare, when the bureaucracy has problems in hospital budgets. They say, well, the fact is that we don't have the money now, and we don't know about 3 or 13 years. We'll just continue to give them the funding and subsidize the costs of the bypassing agents, because we don't have the money for the ITI. But this is a short-sighted view. It needs to be demonstrated that we need to do this and accept the preliminary cost, because if we continue on the bypassing agents, we will still spend the money and more, because after 13 years then we will start accruing more costs than the original ITI would have, and we get less good clinical outcomes. As I showed you before, the bypassing agents are not as efficient. So this is an important consideration. Now I want to make some remarks about the study which I was reminded of yesterday during the panel by our distinguished chairman here, Dr. Lopez, in relation to the question of high versus low dose. And first of all, I emphasize again the issue of personalized treatment. This is from a data set not related to inhibitor patients, but I like to show this slide, and it shows the number of joint bleeds versus factor VIII level in the range of hemophilia severity from severe to very mild. And basically what we see here is that as we approach 15 to 20% of factor VIII level, we get very few joint bleeds, but observe the significant difference between different patients. A patient here at 18% will get these joint bleeds, and another patient here at 0% will get the same level of joint bleeds. So always I emphasize the need for studying individual patients and using population data purely as a guidance. So this study was done, it's a cost effectiveness study, and it was done in Germany. And the paper has various components, and in this instance it is comparing high-dose ITI versus low-dose ITI for so-called poor risk and good risk patients. And the levels of risk are related to the kind of variables which I showed you yesterday in regards to the level of inhibitor in the patient, the level of peak inhibitor, and so on. That is what was used to classify the levels of risk. But then, when you look at the different levels of risk and you compare low to high dose over 18 years, high dose ITI is cost effective for poor risk patients. Patients with poor risk are better in relation to these parameters over 18 years of life. This is looking over only 18 years. Because the low dose patients get approximately 47 more bleeds, 27 additional hospital days, and the cost of the ITI is 1.4 million, and this cost is considered in the German healthcare system to be less overall than the cost of all these treatments. Remember, this is again a particular case. It is Germany, so this is quite an important consideration. If you then look at what another very important aspect is, that they did make the decision on ITI not on the low or high dose, but they looked at individual patient risk assessment. And using individual risk assessment, personalizing the treatment, with the low dose versus the high dose over 18 years, you got 11 additional bleeds. Remember, this is over 18 years. 11 additional bleeds, and not 11 total bleeds, 11 additional. 6 days additional hospital days over 18 years, and the cost saving using the low dose, despite getting these additional problems which needed treatment, was about 1 million. In other words, in this instance, the low dose was more cost effective than the high dose using the individualized, personalized treatment. You got these morbidities, but the cost savings were more than treating these comorbidities. But the model emphasizes that this is dependent on the individual bleeding pattern. And if the bleeds are high, despite the good risk, the high dose is cost effective. Because you see, good risk, those prognostic markers in terms of titer of antibody and so on, which tell you whether you've got a good risk, it doesn't always predict whether you're going to get bleeds. It's an indicator. You always have to continue studying the patients. You could have patients who have relatively low inhibitor titers but still bleed quite a lot because of other features. So this is what this paper basically is telling us. I notice people taking photographs, but you can take these slides. I mean, I've given them to the organization and you can get the paper. You actually have to pay for this paper. So if you want to send me an email, I will send you the paper myself. Okay, we are now going to make some final remarks because I think I need to do this on the whole question of funding hemophilia, because we have looked at in this talk the issues related to very expensive treatment. So let us now discuss why is hemophilia such an expensive disease. Hemophilia is a rare disease. But rare diseases, what we call many times orphan diseases, over the past 10 years have become very, very profitable. Companies make a lot of money. When people tell you, oh, we have to treat hemophilia because of these poor people and there are only a few of them, don't believe it. They want to treat hemophilia because they make much money. I'm going to show you the next slide how much money they make. Okay, so over the past 10 years, okay, from 2000 to 2010, orphan drugs have gone, in terms of average per year economic value, from 351 million to 637 million. I think this is in the United States. And non-orphan drugs have basically stayed the same. So what does this mean? This means that the big pharma industry, the giants of this world, the Glaxos, the Pfizers, are making a lot of money from rare diseases. Look how much the big pharma companies, Biogen, Pfizer, Novo, Bayer, Baxalta, are making from our disease. In 2015, hemophilia was $6 billion and the total hemophilia market was, for hemophilia A, hemophilia B, and hemophilia with inhibitor, $9 billion. Amazing. Absolutely amazing. And this depends on one reason alone, that society, knowing that through treating hemophilia can convert a terrible illness to a normal life, chooses to treat hemophilia. This is all that this is based on. Okay? A huge market. Much of this market now is based on the recombinant products. And we are very happy that we have recombinant products. But let me make one point, which is not actually the subject of this talk. Maybe it can be the subject of another talk. Hemophilia products are divided into the plasma and the recombinant in general. And in general, the recombinant are much more expensive than the plasma-derived. This is a very interesting and ironic thing, because the cost of manufacture of recombinant products is much less, much less than the cost of plasma-derived. You have to keep this in mind. An average factor VIII, which maybe started on the market, let's say 20 years ago, costs to make about 5 to 8 US cents per international unit. Let me tell you that for the plasma-derived it's not so easy, because there are a lot of additional costs in terms of getting donors, paying donors, screening the individual donations. These are very expensive things. But for the recombinant products, these are not necessary. And you can make as much as you like. You just give the cells a bit more food. Very cheap to make. $9 billion. Va bene. Okay, so how do we get? How do we procure? How do we pay for? This is a study coordinated by Brian O'Mahony in Europe, and this is showing the difference in tender outcomes in the competitive processes when you have involvement of clinicians and when you don't have involvement of clinicians. And I recommend that you read the whole paper because there are many other data, but you can see that when you have doctors actually involved, it's interesting that the products become cheaper because the doctors know something about it. Okay, so this is important, but what is also important and shown on this paper is the need to have, very importantly, a governance structure, laws which determine authorities given power and accountability and transparency in decision making. This is a very interesting paper again from Charlie Hay, which shows you the outcomes of the way the British get their recombinant factor VIII. And I believe, Swelly, that this is a system which is not very different from the system which you published in Brazil some years ago. I think with you, maybe it was not exactly like this, but it's the same kind of principle. And basically what you've got here is companies competing strongly over the course of a relatively short period of time, interacting electronically, and observe how lovely it is to see company one dropping its price as a result of the auction. And the important thing which Charlie emphasizes in this paper is that no supplier was excluded from the UK market altogether. And this resulted, in other words, multiple suppliers were allowed. This is something which some people argue against. They say, but if you have a tender, then you give it to only one company and the patients are disadvantaged. That's not true. You don't need to give it to one company. You can have multiple suppliers. You just have competition. And no supplier was excluded. This resulted in an initial cost saving of the National Health Service of about £42 million per year, 28%, increasing annually as usage increased. Only 20% of patients had to change molecules. This is another argument they make. They say, oh look, it's very bad that the patients have to switch from one product to the next. First of all, there is absolutely no evidence that switching from one product to another is bad. Okay, this is una fantasia, this is a fairy tale. But the other issue is that it's not true either. You don't have to have this. And let me tell you that this is the British system. In Australia, we have exactly the same situation. We are not exactly a poor country in Australia. Not a poor country. We have a system in Australia whereby through tendering, we have 3 suppliers. The system is changed every 2 years. The tender is opened every 2 years. And we have a system with 3 suppliers, and at the moment, the number 1 supplier, we are buying factor VIII recombinant from the number 1 supplier. We are nearly 95% recombinant for 25 cents US per IU. I think you're paying a little bit more here in Latin America. And you should be asking the question, why are the rich countries paying less than us? This is what you should be asking about recombinants. Why is it that these drugs are so cheap to make and we, the poorer countries, have to pay more? And I keep saying what I always say when I come to Uruguay, that I know very little about the relationships between the Mercosur countries. But I would say that bigger is better. And you have a combined population here, which I estimate is about 300 million people. 300 million people is a lot of haemophilia, and you should have a lot of power if you use it together. And therefore, I think that I would like to conclude by again praising Sweden. Because Sweden is a cold country and they drink too much and so on, but they actually have a very good attitude. And they say that sometimes the good effects are so great that they easily compensate for all the costs. And that the treatment is considered to be cost saving, but we do not make such high demands, always, in order to consider the use of a medicine. And that people get well and do not experience pain and can live a more normal life using a medicine.